Hi, this is Dr. Anuj Shah, and I'm excited to be talking about the advances in the world of vascular disease walking into 2026. Vascular medicine just had its most transformative year in a decade. Between the new CLTI trials, updated tibial data, major venous intervention breakthroughs, and a rapidly evolving embolization therapy, 2025 forced us to rethink almost every aspect of how we deliver vascular care. The pace of progress has been so rapid that even the tools and concepts we highlighted last year now sit in a completely sharper, more evidence-driven framework. So let's walk through what this means for clinicians heading into 2026. The most decisive new data comes from chronic lymphatic ischemia or CLTI. The BASIL-2 finding confirmed that below-knee CLTI belonged to an endovascular first strategy. Patients treated with endovascularly had noticeably better amputation-free survival than those treated with vein bypass, roughly 53% experiencing major amputation or death compared to 63% after bypass. Even more compelling, patients lived longer without limb loss, around 4.5 years with endovascular therapy compared to just over 3 years with surgery. This reshapes the standard approach to tibial disease. Alongside this, the LIFE-BTK trial delivered some of the most impressive 2-year tibial results we have seen. The everolimus-eluding reabsorbable scaffold significantly outperformed balloon angioplasty, with nearly 70% of patients achieving the primary endpoint compared to 45% in the angioplasty arm. Restenosis was nearly cut in half and reintervention rates were meaningfully lower. LIFE-BTK signals a true shift in BTK or below-the-knee revascularization, a drug-eluting reabsorbable platform that may serve as the DES moment for tibials. We also had the new perspective on the earlier BEST CLI data. When patients have a strong great saphenous vein conduits and primary femoropopliteal disease, bypass still carries a real advantage, reducing a major limb loss or death from almost 57% compared to 43%, but that advantage disappears the moment conduit quality drops or when disease becomes tibial dominant, and in those cases, the BASIL-2 and LIFE-BTK evidence, as mentioned above, persists and takes precedence. Taken together, 2025 gives us the clearest roadmap yet: bypass when conduit and anatomy align, endovascular when they don't. It's no longer endo first versus open first, it's truly anatomy first vascular care. Another important update comes from the Liberty 360X extension analysis released this year. This massive real-world registry followed patients with Rutherford class 2 through 6 disease and confirmed that even advanced CLI patients achieve better than expected survival and limb salvage with modern endovascular techniques. 5-year survival in the non-ambulatory CLTI cohort exceeded what earlier era randomized control trial had predicted, and freedom from major amputation was significantly better than historical controls. The Liberty 360S reinforced the central theme of this year. When performed with contemporary device and contemporary algorithm, endovascular therapy can achieve outcomes once thought almost impossible. Medical therapy also has become clearer in 2025. Voyager PAD remains the backbone of post-revasc management. Low-dose rivaroxaban plus aspirin consistently reduced major adverse limb and cardiovascular events compared with aspirin alone, and this year's deeper analysis clarified that the greatest absolute benefit comes from high-risk patients, those with diabetes, prior intervention, infrapopliteal disease, or multivessel PAD. The bleeding cost remains small and clinically manageable for most patients. So as we head into 2026, dual pathway inhibition should remain the default unless bleeding risk is prohibitive of that. In the device space, the final SweatPad analysis confirmed that paclitaxel coated devices do not improve wound healing, amputation prevention, or long-term survival compared to plain balloon or stents. So the entire excitement about drug-coated balloon has somewhat fizzled out. Mortality signals were again not supported. The result is a more selective focused use of drug-coated balloon device and renewed attention on non-paclitaxel platform now entering the clinical trial pipelines. Atherectomy remained widely used but under scrutiny. A 2025 meta-analysis of more than 300 studies showed good patency rate and low amputation rate, but extreme heterogeneity and minimum randomized evidence. Procedural cost, time, and embolic risk continue to be consideration, and outcomes don't consistently exceed simple therapies. The message is pragmatic. Atherectomy remains a tool, but not a default solution. The world of venous disease also has had major forward movement in 2025. For iliofemoral DVT, the updated clot driver registry demonstrated durable symptom relief and very low rates of post-thrombotic syndrome at 2 years, even in patients with chronic thrombus. And enrollment of the Defiance randomized trial was completed this year, and early signals suggest that mechanical thrombectomy may outperform anticoagulation alone in reducing PTS or post-thrombotic syndrome severity. If confirmed, this will shift standard DVT care in 2026. Similar to DVT, pulmonary embolism also continues evolving. The latest peerless analysis showed that large bore mechanical thrombectomy reduced clinical deterioration events and shortened ICU stay compared with catheter-directed thrombolysis while maintaining comparable bleeding rate. This gives us clinicians a powerful option when lytic therapy is risky or contraindicated. When it comes to chronic venous obstruction, including May-Turner syndrome and post-thrombotic iliac occlusion, 2025 data reaffirmed long-term durability. 1-year primary patency rate approached 98% and 5-year patency stayed in the mid-70s. Ulcer healing, edema resolution, and quality of life improved were consistently strong. Newer analysis show that earlier intervention lead to better wound outcomes at 2 years, pushing us towards timely stenting in severe obstruction cases. Varicose vein therapy continued its modernization with uniformly high closure rates across thermal, glue, and mechanochemical techniques. While their side effect profiles differ slightly, their efficacy remains excellent. The emphasis has shifted towards choosing the modality that best fits anatomy and patient preference rather than debating which one is better. Finally, and this is where last year's conversation became relevant again, imaging and precision-guided vascular care took a leap forward in 2025. AI-augmented duplex system can now classify waveform and predict flow limitation and automatically map tibial vessel for CLTI planning. These tools reduce variability between operators and create more consistent surveillance pathways for wounds, bypass, and endovascular reconstruction. It builds directly on the idea we emphasized last year, that better imaging leads to better decision-making. Now these tools are materializing with real-world clinical utility. There were also meaningful progress in musculoskeletal embolization, especially the genicular artery embolization for osteoarthritis or knee pain, something we touched on last year but now has stronger numbers behind it. Updated results from the Genesis 2 trial multicentral experience showed that sustained pain reduction out to 12 months, with over 60% of patients achieving clinically meaningful improvement and strong safety profile. Early US analysis from 2025 mirrored those findings, reinforcing that GAE is a promising, minimally invasive option for patients who are not good surgical candidates or who don't want to go for a total knee replacement. A separate randomized trial, the BAGLA trial, continued to show the embolization performed significantly better than the sham procedure in early pain reduction and functional improvement. The longer-term data from the Japanese cohort from the Okuno and colleagues also remain consistent, with more than 80% of the patients experiencing meaningful pain relief at 6 months and durable benefit at 3 years. GAE continues to demonstrate that targeted microvascular therapy can slow inflammation, reduce synovial hypervascularity, and meaningfully improve mobility in the right patient population. The bottom line as we enter 2026 is this: vascular medicine is moving faster than ever, the evidence is stronger, the treatment pathways are clearer, and the potential to save limbs and preserve mobility is greater than at any point in the last decade. Our responsibility now is to turn this new data into immediate real-world benefit. Thank you so much.